Ajit sir, 3 hot seaters have joined.
Okay.
I'll put up the names on the list as we start.
So Ajit, how many slides?
How much you want?
100.
मेरा slides ज़्यादा नहीं है.
45
Each slide
minutes.
has content.
But 45 minutes?
35, 40. It should be all right. We will keep a little bit time for discussion because diabetic retinopathy, no, mostly they may have a lot of questions because it's their subject mainly.
I think
Because
we
it
are
is
live.
not.
We are live now. Let's start.
We are live, sir.
Yeah.
Good evening, everybody. Welcome to iFocus Online Lecture 180 and Retina Session 32. Today, we're honored to have Dr. Ajit Babu to speak to us on diagnosis of diabetic retinopathy and classification systems. We'll also talk to us about non-proliferative diabetic retinopathy. Now, may I invite Dr. Lalit Verma to introduce the speaker to us.
Ajit Babu does not require introduction because he is a national figure and maybe internationally also. But I know him for so many decades because he was with us at RP Center for a long time and he had a stint at Baltimore. But what I know about Ajit, very dear friend, very dear colleague, very friendly person, more important, very, very clear understanding of the subject. Nitty-gritty, he goes into nitty-gritty of subject, and hence I think we have him here. Because he has very clear concepts, and he's a very fine surgeon. I've seen a lot of his pre-post diabetic vitrectomies, and very, very fine dissection he does. So one of the most apt person to educate us on a very common disease, that is diabetic retinopathy, which no ophthalmologist can afford to miss actually. Because whether you are a plastic person or whatever, cornea, retina. So retina people in any case ought to know everything about it. But I believe if we have to eradicate or control or prevent blindness because of diabetes, because we have two things, DME and PDR for this. So everybody ought to know, each ophthalmologist, because all of us have to contribute to prevent blindness because of diabetes. And that is the reason I think this will and should attract a lot of discussion and audience. And because Ajit Babu is a great teacher, is an educator. And I have heard him in various conferences on lecturing on diabetes, angiography, lasers, surgeries also. So he's one of the most apt person to educate all of us. So on behalf of the entire CFS family, he's part of CFS only. We welcome Dr. Ajit. He has been past president of All India Film Society, past president of VRSI, and a lot of other post-administrative he has held. So we have with us one of the pioneers in retina, Dr. Ajit, to tell us about diabetic retinopathy. Primarily, he'll be focusing on, you see, NPDR, but I think we will have a lot of discussion regarding classification and NPDR. So NPDR is one area where a lot of trials have not been held. Recently, people have started focusing on trials, but major trials have been held on DME and PDR and vitreous hemorrhage. But NPDR is picking up now. So over to Ajit Babu. I will not, keep talking unnecessarily. So let's have Ajit Babu sharing his slides.
Okay, can you see the slides?
Yeah, we can see.
Thank you, Lalit, for that very nice introduction. And I do like to share my knowledge, whatever little I have. And particularly diabetic retinopathy and diabetes is a special subject where I do have a special interest. This is mainly because I have seen a lot of families going down in their life because of mismanagement of diabetes, and from the beginning onwards. It's not moving.
Click on the slide.
Slides are not moving.
Slides are not moving.
Click on the slide, it will be. Or you want to reshare?
No, reshare. I will do that maybe. Yes, it is now moving.
Yeah, perfect.
So, yeah, if you see the world scenario of diabetic retinopathy, we have countries like China, India, and USA leading in number of diabetics. If you see, China is almost 109 million diabetics are there. India 69, but now the count is much more than what this slide is showing, and 30 million in USA. All this red is in high prevalence of diabetic retinopathy and diabetics in these countries. So India is almost second and the capital, new capital, going to be new capital for diabetes in the world. So that's why it is very, very important for us to understand the diabetes as well as diabetic retinopathy. If you see in India, the prevalence is much more in South India. You can see the red in Tamil Nadu, Kerala, and then brown in Karnataka, Goa, Punjab. Then a little bit pink is seen in Telangana, Andhra Pradesh, Madhya Pradesh. That way, the various prevalences are in the country is available. If you see the overall prevalence of diabetic retinopathy among diabetics is 35%, and the PDR is 7, DME is 7%. Vision threatening diabetic retinopathy is 11.7. This is because PDR and diabetic macular edema combinedly give to this higher percentage. Another important aspect of diabetes in our country or countries like us, developing countries, compared to developed countries, is the active involvement. Prevalence, highest prevalence of diabetes is 65 plus in developed countries, whereas in India and other developed countries, the peaking is at 45 to 64 years. This means that active earning age is getting affected. So in order to diagnose the diabetes, that is more important, first of all, because there is no annual screening program, or people are not tuned to annual screening. So a person should have any diabetic symptoms, should be advised to go and check for blood glucose. And if anything is plasma glucose is more than 200, definitely he is a diabetic, but fasting blood glucose 126 or above should raise the alarm. And 2 hours plasma glucose above 200 is definitely again on oral glucose tolerance test. Indicates that he's a pre-diabetic, and pre-diabetic means that in next 5 years time, this person is likely to develop diabetes and require treatment. Who is at risk? American Diabetic Association has recommended that screening for diabetes should be done for all people above 45 years. If they are not proven diabetics and it is normal, then it should be repeated once in every 3 years. And screening in younger age is also indicated. If you see the risk factors for early diabetes is obesity, first degree of relatives of diabetics, and those belongs to high risk ethnic groups, and who diagnosed with gestational diabetes. Again, gestational diabetes indicative of pre-diabetes, Again, these people are prone for development of diabetes within 5 to 10 years. And if the baby is large, like 3 or 3.5 kgs, then again, there is a propensity for the person to be diabetic. And hypertension is associated with diabetes. So whoever is hypertensive, they should be screened for diabetes. Again, in the lipid profile, one need to observe whether HDL levels below 35. Below 35 means that there is a sedentary nature of the person. Normal is 40, and above 40 is means that the person is very active and doing regular exercise. We can really assess whether the person is physically active or not just by seeing HDL levels. Triglycerides more than 250 again is a high risk for the development of diabetes. And whenever there is a doubt, one should undergo impaired glucose tolerance or impaired fasting a test to know about diabetes. And there are several studies, especially in the south, majority of them are in the south. They estimated that prevalence of diabetes in the population is almost 4 to 8%. And the diabetic retinopathy among diabetics is very low percentage is coming here. It's like 10% to 22%. And if we see the modifiable risk factors for diabetic retinopathy among diabetics, this is again very important, where DCT trial has shown that tight control of HbA1c reduces the development of diabetic retinopathy, especially worsening of 3 or more steps. This we will deal with later on, is almost like reduction of 75% occurs. And tight blood pressure control again shows that 35% of the people there will be a reduction if tight blood pressure control is done. There are studies which showed that field study which used fenofibrate. It's mainly to prevent the triglycerides and LDL and VLDL. It shows that almost 31% of the people will require less of laser in diabetic macular edema. And obesity is again shown, especially larger waist to hip ratio, shown that over 7 years follow-up, there is a higher propensity for diabetes. Non-modifiable risk factors. One need to understand that certain things we cannot change in diabetics for their progression of diabetic retinopathy. The most important thing, important of that is duration of diabetes mellitus, puberty, and during pregnancy. That's why the frequency of visits during pregnancy is much more shorter, which we will again explain later on. Here, going through 2 studies, that is DCCT trial and EDIC. Both are part of the same trial. DCCT was conducted where the 2 arms are either intensive treatment or the conventional treatment as 2 arms, and it was conducted for 10 years. After 10 years, the same population, whoever want to be part of the study, was extended as EDIC trial, where there is no strict control, either intensive or conventional. This treatment was continued for next 82 days. If you see the EDIC trial and DCCT trial, the intensive therapy certainly resulted in a better control, and the progression of 3 steps or more is reduced by significant number in both the trials. this is exactly what I have told, that initially DCCT, where the intensive control, where the control is HbA1c level is 7.2 and an average, whereas conventional treatment, the average HbA1c is 9.1. However, in EDIC, that is the continuation of the DCCT trial population, whoever interested in extending to be part of this study, their HbA1c level is around 8. So we'll see what that has resulted in treatments. If you see, this is a 8.5-year rates among the DCCT trial population. A primary prevention has resulted in intensive therapy almost like 5 times less, whereas in secondary intervention, it is 3 times less with intensive therapy. And if you see the DCCT trial, almost like 75% of the risk reduction has happened over 6.5 years. And in EDIC trial, the first 10 years of the EDIC trial, that is total 18 years, first 10 years, there is a good reduction of the progression of diabetic retinopathy that has happened. That is mainly because the initial 10 years intensive control in DCCT trial has resulted in good results even during first 10 years of EDIC trial. Like if you see here, almost like among the 18 years, 52% of risk reduction was there versus conventional, whereas this benefit in the last 11 to 18 years, the risk reduction has reduced, like 56% in first 1 to 10 years, whereas 27% risk reduction in 11 to 18 years. This means that intensive control has a very good role in preventing the progression of diabetic retinopathy when the person does a good blood sugar control. And UKPDS, again, I do not go into the details of the study, but the major conclusions that it has resulted, again, showed that there is a good risk reduction of almost 17% reduction in two-step progression of diabetic retinopathy. Laser photocoagulation was need for laser photocoagulation is reduced almost in 30%, and with occurrence of vitreous hemorrhages is reduced by 24%, 23%, and cataract extraction by 24%, and legal blindness by 16%. Means it's always showing that good control is more important in these studies. And if you see the complication rate, again, here 3 studies were compared. Out of that, DCCT EDIC trial conventional, DCCT EDIC trial intensive group, and this is Pittsburgh epidemiological diabetic control trial. If you see this, conventional and the Pittsburgh diabetic control trial has higher percentages of each complication like retinopathy, PDR, CSME, laser, both scatter and focal laser, nephropathy and renal insufficiency and replacements and amputations also, compared to the intensive group of DCCT and EDIC trials. Now let us see the other systemic effects. If you see, most of the diabetics are more prone for cardiovascular diseases, like almost 50% of the people, death happens in non-insulin dependent diabetes mellitus is because of cardiovascular. Renal by 11%. Cancer is not particularly related to diabetes, but in this population that has resulted in deaths. Then most of the diabetics we should evaluate for the 2D echo in so that we can detect the dilated cardiomyopathy. This is very, very essential. If you can detect the dilated cardiomyopathy, then you can prevent and treat it so that we can postpone a lot of complications that can happen. And these people are prone for significant blocks in the cardiac vessels, especially atherosclerotic changes are more prone in diabetic patients. Diabetic feet is another important aspect which we neglect in the clinic. As an ophthalmologist, we should also look at their feet so that we know that what changes are happening in these people. If you see, 60 to 70% of diabetics have foot neuropathies, and 25% of the diabetics have foot ulcers. 25% of the patients with foot ulcers almost gone into amputation. In otherwise, foot ulceration is the precursor for almost 85% of the amputations in diabetics. This is very, very important, because once the amputation happens, his earning will affect. Not only that, physical exercise, which is the key factor in controlling the blood sugar levels, also will get hampered. You have seen there are two kinds of foot changes here. One is trophic ulcers, where in diabetics, if you see a trophic ulcer like this will take almost 6 months to 8 months for complete healing. This is with the proper treatment and management. And if you see here, it is almost gangrene, and if this gets secondarily infected, overnight you may have to go for amputation, which is very, very significant, and one should be very aware of this complication. In addition to this, diabetics also prone for diabetic nephropathy, anemia, lipid derangement, and nervous system problems as well. And diabetics are almost 10 times more prone for end-stage renal disease. Again, screen got paused.
If the internet connection is unstable, it can happen.
Okay.
So now it's okay.
Now it's all right. Yeah.
Right.
Now let us come on to the eye proper, because till now we tackle all the systems. Because as an ophthalmologist, if you are sitting in the clinic, you cannot say that, okay, I only concentrate on eye, even in diabetic patients. You should always look for all the system effects. Rather, in my clinic, I always investigate, and then I say that you need to go for this nephrologist or a cardiology opinion and all kind of thing. So you should diagnose what is wrong with his systems, because management of diabetic macular edema a lot depend on the systemic parameter derangement, which I think in the next class, Dr. Kim will be dealing with it. If you see the ocular manifestations, chronic blepharitis, dacryocystitis, recurrent erosions, reduced corneal sensations, and secondary effects. And diabetics are more prone for endothelial dystrophy. And POAG and juvenile open-angle glaucoma are also very, very common. And advanced diabetic retinopathy changes can also lead to iris and angle neovascularization. There is another way of getting an angle and iris neovascularization is ocular ischemic syndrome. There can be a carotid changes. So always there is an indication for carotid Doppler in diabetics to look for narrowing of the vessels. And these patients are prone for resistant dilatation in the clinic. Cataract is very common. Especially we need to alert the patients, all diabetics, that your blood sugar control should be very good for having a proper clear lenses. If the sugar control is not there, certain times intermittent cataracts can happen with a history of 1 week sudden loss of vision. Now let us move on to the diabetic retinopathy now. Out of this, there is again type 1 and type 2 diabetes. Everyone of you know about it. In this type 1 diabetes, if you see the percentages of occurrence, prevalence of diabetic retinopathy with duration of the type 1 diabetes, almost 10 to 15 years of diabetic duration of type 1 results in almost 75 to 90% of the occurrence of diabetic retinopathy in these patients. So within 10 to 15 years, they will have some form of diabetic retinopathy. So screening is very, very essential. Whereas in type 2 diabetes, you are seeing almost above 16 years also of duration of diabetes. 60% of the people only will have some form of diabetic retinopathy. Means screening can be a little bit liberal in type 2 diabetes, whereas type 1, it need to be very, very close. And whenever the changes happen, with my experience, I'm telling, the severity of changes are much more with type 1 diabetes than type 2 diabetes. Now we are going a little bit more focused on to the studies a bit more now. If you see the ETDRS is the first planned, DRS and ETDRS has the first planned studies, how they did go about it. That's where the classification and findings and their documentation are very, very essential. If you see this picture, there are 7 fields which are there. Each field, actually you are seeing all counts of 7. In this, each circle represents 30 degrees photograph. So 7 photographs are taken and each field is again evaluated for 30 parameters. And each parameter again subclassified. I will not go into great detail of it, but this is the grid which is centered on to the macula. This is mainly to judge how far is the lesion from the center of the macula. If you see here, the 500 solid line, this is 500. This is one disc, that is 1500 microns. And this is 2 disc areas. And this is 300 microns. So that's how you can say the significance of the hard exudates or even the succinate ring in diabetic macular edema. Now, to diagnose a mild to moderate non-proliferative diabetic retinopathy, the basic lesions mainly of diabetic retinopathy is microaneurysms, inter-retinal hemorrhages, hard exudates, and cotton wool spots. Cotton wool spots have proved later that they are not so important in the classifying whether it is severe, moderate, mild, moderate, severe, very severe non-proliferative diabetic retinopathy. But microaneurysms are main sign that you can say that this patient could be a diabetic. However, history of diabetes is very important. There are other diseases where again microaneurysms can be present, so you need to rule out them, especially radiation retinopathy. You can see very often that microaneurysms can happen. Inter-retinal hemorrhages, again, there are a lot of number of diseases that can result into inter-retinal hemorrhages. Again, the type of inter-retinal hemorrhages are very, very important to recognize, because very common diseases, one is diabetes and second is hypertension. Hypertension classically presents with flame-shaped hemorrhages, whereas diabetes is dot and blot hemorrhages. So these need to be identified. Hard exudates are mainly yellow-white areas. You can see in this picture. Again, you need to follow with this. Whereas microaneurysms, inter-retinal hemorrhages, and hard exudates, they can present wax and wane. So it may take months or certain times years. Hemorrhages are a little bit less, means faster to resolve and reappear. whereas microaneurysms and hard exudates takes months to years in appearing and disappearing. Here I am showing one color photograph and a red-free photograph. Red-free photograph always delineates the lesions much better. This is, I have a reason for this. I will explain you in a short while. Here, if you see in the color photograph, you are seeing some red spots here and some white lines, but not so clear in the color fundus photograph. Whereas when it comes to red-free photograph, you are seeing the collaterals very clearly here, the line of the normal and abnormal margin and the blood vessel blockage. So it's a BRVO with vascular blocks here in a diabetic patient with collaterals, which is very clear here. This is mainly because of these photographs. Again, if you see the ETDRS, lot of photographs are given, like standard photographs for comparison, what is the grade and all kind of thing. And here we are showing you how detailed way they have evaluated. That's why the knowledge what we gain now is because of such a meticulous planning of the studies. If you see the mildest standard of hemorrhages and microaneurysms, they have given one photograph and they refer this as a standard photograph 1. So wherever you study, they will mentioning about a standard photograph 1, and that you need to have the mental impression of that. And standard photograph 2A is the intermediate standard for hemorrhages and microaneurysms. Again, they have given this classic picture. And standard photograph 2B is severe standard for hemorrhages and microaneurysms, the number of hemorrhages here. And again, the grading is given very clearly here about grade 0, 1, 2, 3, 4. And each one is referred to the photographs within the grades. And whenever they could not grade, then it's always grade 8 is cannot grade. And rest of the grades are here very clearly given, like grade 1 is questionable hemorrhages, grade 2 is definite hemorrhages, and grade 3 is hemorrhages and microaneurysms greater than or equal to standard photograph 1. Means I referred to that. I will not go into the great detail of that, but each lesions they have given with good examples and good photographs, which we will go through very quickly because it's a big classification. Again, here it comes to the venous bleeding. Venous bleeding, again, standard photograph 6A, less severe venous bleeding. You can see the bleeding here. Means they are saccular dilatation of the veins, narrowing and dilatation alternately it will be there. And it is very clear here. That's why it is standard photograph 6B with more severe standard for venous bleeding. Okay. Now, venous abnormalities, not only venous bleeding, venous narrowing, venous loops. Loops we have seen in many cases. We thought it's not included in the classification, but it has been included and it's been noted all through. And reduplication of the veins, again, it is there. Now comes to the another very common lesion, that is intraretinal microvascular abnormalities, or IRMA. IRMA, again, it's standard photograph 8A, less severe of the two standard grading. In this, they said soft exudates is given and IRMA is given. These are for mild soft exudates, and these are the for IRMA. This one is IRMA and this is severe IRMA. Examples of severe IRMA. Here it is showed that standard 8B, severe standard for IRMA. So you can, they subgraded even the lesion of IRMA. So again, the grading is very clearly mentioned here, cross referring to the photograph 8A, 8B, etc. And grade 8, as I told you, is always cannot grade. And again, hard exudates. Again, it's a mild hard exudates is this one, and very severe hard exudates are here. All standard photographs are given in the study. Why I'm mentioning is this is the greatest detail they have taken and observed, so that worsening by 2 steps or 3 steps is always compared. So if you go into the diabetic retinopathy disease severity scale, you can see that no apparent retinopathy is, no abnormalities will be observed. Mild non-proliferative diabetic retinopathy. Whenever few microaneurysms are appeared, means the diabetic retinopathy has started. And when it is more microaneurysms are appearing, then it is moderate non-proliferative diabetic retinopathy. Severe non-proliferative diabetic retinopathy is any of the following here. You can see the number of inter-retinal hemorrhages, very, very important. You can see more than 20 inter-retinal hemorrhages in each of the 4 quadrants. All 4 quadrants, the inter-retinal hemorrhages of more than 20 should be there to be called as severe non-proliferative diabetic retinopathy. Or there can be a venous bleeding in 2 quadrants, or prominent intraretinal microvascular abnormality in 1 quadrant. Means they have given 3 lesions to call it as a severe non-proliferative diabetic retinopathy. So while examining the fundus, you should look for all these, which I have showed you what are the lesions, how they look like. Proliferative diabetic retinopathy, I will not be dealing in great detail here. It will be dealt in next class, probably during next week. 1 or more of the following, like neovascularization, vitreous hemorrhage, or pre-retinal hemorrhage. If they are there, then it will be called as proliferative diabetic retinopathy. So let us see. They have given 3 lesions, that is in severe intraretinal hemorrhages in 4 quadrants, and venous bleeding at least in 2 quadrants, and moderate to severe irma at least in 1 quadrant. These are the 3 characteristics. If one of them present, then it is called severe non-proliferative diabetic retinopathy. Whereas if 2 are there, then it is very severe non-proliferative diabetic retinopathy. So you should see whether both out of 3, at least 2 are there, then you can say it is very severe non-proliferative diabetic retinopathy. There is a reason for this thinking. And if you see the collectively International Clinical Diabetic Retinopathy Severity Scale, they have not defined the very severe non-proliferative diabetic retinopathy here. Whereas ETDRS based clinical diabetic retinopathy severity scale, they have defined very severe non-proliferative diabetic retinopathy. This is very essential also. After ETDRS, they have understood why we should grade as very severe non-proliferative diabetic retinopathy. And if it is proliferative diabetic retinopathy, then early proliferative, high risk proliferative, and advanced, actually. It is not severe, advanced proliferative with secondary complications. So here it comes DRVS study, ETDRS study, DRS study, DCCT, and UQPDS. All these studies, summary of that, they have amalgamated into one good classification for diabetic retinopathy, which is simple to adapt clinically, so that everyone can follow and understand and classify in the clinic itself without much difficulty. If you want a difficult classification of diabetic retinopathy, again, they have given different levels of diabetic retinopathy on the severity scale, from 10, severity scale 10 to almost 90. So 85, if you see advanced PDR here, and if you see 65, moderate PDR, mild PDR is 61, above 60 are all PDRs, and different grades of non-proliferative diabetic retinopathies are below 60. So whenever you are classifying, certain times you can take the help of other investigations in diabetic retinopathy. Especially, as I told you, red-free photograph is very good. If someone can take and then compare with the color photograph, that is fine. If you cannot and you have angiography in your at your disposal, you can also do. Here you are seeing a very severe non-proliferative diabetic retinopathy. Here you can see the venous beading here, almost 2 quadrants here, and IRMA here and here. So it is definitely, and if you see the capillary non-perfusion in ETDRS, one aspect which they have not touched upon is capillary non-perfusion areas. The extent of capillary non-perfusion areas is nowhere mentioned in the classifications of diabetic retinopathy. Why it is important for us to classify a non-proliferative diabetic retinopathy is because of this slide. This is very, very important slide. If you see mild non-proliferative diabetic retinopathy, you are classified it as the risk of 1 year progression to proliferative diabetic retinopathy is only 1%, whereas 5 years also it is only 15%. Let us see very severe non-proliferative diabetic retinopathy. At 1 year, almost 45% of the persons who are with severe non-proliferative diabetic retinopathy go into proliferative diabetic retinopathy. That means within a year, he requires panretinal photocoagulation. What will happen if you don't treat and if the patient goes back and comes after 2-3 years? There can be a lot of bleeding and the vision may get compromised. That's where with vision threatening retinopathy can happen with complications. So how to manage non-proliferative diabetic retinopathy? Again, no diabetic retinopathy, then clinical examination is just enough. Investigations for no diabetic retinopathy, don't investigate at all. You can take a color fundus photograph as a baseline, and if there are any changes which are happening, you can compare with that. Otherwise, usually at this stage, annual screening is just sufficient. If it is mild to moderate, then again you want to document if there are some macular changes, then you can do OCT, color fundus photograph can be done. If the hemorrhages are larger in size, certain times you may have to suspect a neovascularization underneath. If there is a hemorrhagic patch over the disc, very rare for hemorrhages to happen over the disc, again you need to suspect a neovascularization. These cases you may have to subject for angiography in this case. And when FFA is done, it is mainly to rule out the neovascularization. Certain times in diabetic macular edema, whether the center is involved or not, and whether what is the type of leakage. Mainly the leakage can be of 2 types, mainly to identify leaking microaneurysms for a focal diabetic macular edema, and a capillary segment leakage, it happens mainly in diffuse diabetic macular edema. This I will skip this slide. This also, the ischemic maculopathy, again, one need to suspect when the vision is very poor, and you may have to do a fluorescein angiography or now OCT angiography to see the capillary dropout. And when there are so many hard exudates and hemorrhages and capillaries, microaneurysms are there, then you need to classify whether it is clinically significant or clinically non-significant, center involving, non-center involving diabetic macular edema. So FFE is mainly to differentiate IRMA from NVE. It's very important. Unexplained visual loss, again, you need to do FFA. And capillary non-perfusion areas, again, you need to, and once laser is done, and if there is NV is persisting, again, you need to see where is the defect, you can see. This is the diabetic macular edema, which again in the next class they may deal with it. And OCT, again, you need to see whether there is any vitreomacular interface abnormalities are there or not. And what is the type of diabetic macular edema. And retinal thickening, again, monitor with the treatment is effective or not. And what type of treatment we need to give. And what prognosis we can give, like drill and all. This, I think, again, Dr. Kim will be dealing with these things. And this classification also, I will leave it to Kim for explaining. OCT angiography is the new tool. Again, we can see the different layers of retinal vasculature and their loss. You can see the capillary loss in this on OCT angiography. And wide field imaging is also essential, though the macular area study is regular photography is much better than wide field. Wide field is important for the peripheral field. If there are capillary non-perfusion and there is a persistent macular edema, treatment of the peripheral capillary non-perfusion can help in reduction of the diabetic macular edema. So once we understand the diabetic retinopathy, when to dilate and examine the first examination or follow-up examinations, any diabetic below 30 years, by 5 years, one should look for the diabetic retinopathy screening. Above 30 years, whenever it is diagnosed, you should examine. During pregnancy, first trimester itself, you should start examining these patients. And recommended follow-ups are none or minimal diabetic retinopathy, just annual follow-up is just sufficient. Mild to moderate non-proliferative diabetic retinopathy with no macular edema, 6 to 12 months is just sufficient. But when macular edema appears, the follow-up duration will reduce to 4 months. If the non-proliferative diabetic retinopathy is moderate to severe, then 3 to 4 months is essential. During pregnancy, as I told you in the beginning, every trimester it need to be examined. And very severe non-proliferative diabetic retinopathy, I already told that this is high risk for progression to PDR within a year's time in significant number of people. So early PDR and very severe non-proliferative diabetic retinopathy are considered stays to consider photocoagulation or injections, whatever is the treatment the doctor or the treating physician decides. High-risk PDR and CSME definitely requires treatment, and it requires high-risk PDR. I would say you should not leave the patient to go back without getting the laser done or the injection done. In conclusion, diabetes mellitus and diabetic retinopathy, assuming global epidemic, and diabetes can lead to life and sight-threatening complications. It's not only the complications to the patient, actually it is the whole family gets affected, and the whole morale of the family, it goes down. Good control and regular follow-up is very, very key to prevent deaths and blindness due to diabetes. This is one point which I want to drive this evening. And ophthalmologists should be prepared to handle the diabetic retinopathy. I didn't say the retina specialist, it is the general ophthalmologist should take care of the diabetics. Because of that, if you see the initial part of that, I said very detailed systemic workups and what all to be done, and in different studies, how important it is to have a intensive control of diabetes. These two are the key factors. Staging of non-proliferated diabetic retinopathy is very essential to predict the onset of PDR that I already shown in that slide. And PDR is very essential stage where counseling of diabetic patient. I would rather spend more time while after diagnosing non-proliferative diabetic retinopathy rather than advanced PDR where I can straight away say you require surgery and you go for surgery. So here you need to stress the importance of good exercise and timely food, and what type of food you need to the patient need to take, and what is the importance of the medication, either insulin or oral medication, and then different systemic parameter evaluation, and then directing them to specialists is also equally important, because if you control the body, automatically the diabetic retinopathy also comes to a stable status. DME and PDR definitely need specific treatment approaches, and the next two classes are designed to address one, diabetic macular edema in next class, and advanced PDRs in the following class. So with this, I would rather say I will conclude my presentation, but now on I expect a lot of discussion, which 10 minutes are there, and I am ready to answer. Thank you.
Thank you, Ajit, for this wonderful talk on a very, very common subject. You could stop sharing.
Yeah. Right.
Very, very common subject, which, as I said in the beginning, that everybody should know, you see, irrespective of what specialty you are into. So if there are any questions, we will love to take them from the hot seat benchers. I saw one question there, but that was, you see, if any patient has a splinter hemorrhage onto the neuroretinal rim, will it point towards glaucoma or any other reason?
It depends on splinter hemorrhages in a diabetic patient, and the cupping is not much. Again, it can be a pointer, but splinter hemorrhage do not suggest for NVD.
The other thing which splinter hemorrhage can is sometimes risk for AIUN. See that if it is on the disc margin, so you should start suspecting NTG, LTG, or AIUN in such patients. These three things come to my mind once I see a splinter hemorrhage, which is, you know,
the hemorrhage need to be of a good size, then only you need to suspect NVD. Yeah.
No, NVD, in any case, you see, we will confirm it. But besides NVD, presence of isolated or maybe in the setting of mild to moderate NPDR, specifically if patient is complaining of a sudden visual loss, I would suspect AIUN first, then LTG or NTG, because disc glaucomatous suspicion, if it's there, then diagnosis written right there. If not, you see, then LTG or NTG also should be taken into consideration. Does this answer your question, whosoever asked, Dr. Sohni?
Sohni.
Yeah.
So, any other questions?
Yeah. So there are a couple of more questions.
Yeah, please carry.
So how do you differentiate IRMA from NV clinically?
NVE clinically. Usually IRMA do not cross the vessels. It is in between the vessels. Whereas the NVE can cross the vessels. Number two is IRMA is always intraretinal, within the substance of the retina. Whereas NVE always comes above the surface of the retina, and it is into the vitreous cavity, certain times posterior along the posterior hyaloid or into the vitreous cavity. And if you do a angiogram, means that is final, obviously, where the leakage will be profuse in NVE. In IRMA, it's expected to not to leak, or there can be a minimal leak, not so much.
I think Dr. Ajit has said very classically, IRMA does not leak and NVE leaks. The other thing, apart from intraretinal location and surface, is the caliber also. You see, the brush-like vessels, very brush-like vessels will always point to NVE. But if there are regular kind of vessels, small caliber vessels, and slightly more, not brush-like, the suspicion is IRMA. So apart from that, I think three things is already told. 100% confirmation, if you want, I think you should go for an angiography. But clinically, I think these 3 points should suffice to differentiate between IRMA and. But IRMA rays, you see presence of that I would like that all of you, all the listeners should understand one thing, which, one takeaway from this lecture is all of us should remember 4-to-1 ka rule. That because NPDR, the basic thing is 4-to-1 ka rule, because that points towards severe or very severe NPDR. These patients, you see half of them, 46% in 1 year and 75% in the 5 years.
That's why I like that slide very much. Actually, my lecture on diabetic retinopathy will not go without that slide. It has so much of message to give with 1 year and 5 years instances of NPDR progression to proliferative diabetic retinopathy. Till severe NPDR, the percentage is very less. Whereas very severe NPDR, it is jumps to 45% in first year and 72% by 5 years, which is very, very significant number of patients converting into proliferative diabetic retinopathy. Which
all
is
of you, a lot of other questions coming up. Let's.
Please.
Is it apt to give intraretinal triamcinolone for treatment of NPDR in cases where anti-VEGF is contraindicated? You see,
only NPDR. You tell Lalit.
I don't think so. NPDR,
NPDR do not require any treatment.
Except if they are accompanied by
direction. I want to tell, because there are some studies for induction of the PVD in NPDR. Because the very premise of this induction of PVD in NPDR is to prevent severe forms of proliferative diabetic retinopathy when it occurs. So if the posterior hyaloid is not there, the neovascularization cannot be prolific. So you cannot get the fibrosis, you cannot get a florid neovascularization. That's why a lot of studies are done to induce the PVD in this case.
Yeah, I agree. Let's move on. Because Sohini, what you were asking, Meenal was asking. So NPDR, mild to moderate, we don't care at all. Only one is, of course, severe, very severe. And if it is not accompanied by DME, we do not treat at all.
Yes.
Only treatment where my tentacles will go up is very severe NPDR in a fellow eye of a patient, other eye has been lost because of complication of PDR. Then you see, I may start warding this patient or start lasering also for a very severe NPDR.
Good laser is...
very severe NPDR in a one-eyed patient or very severe NPDR in a patient where a fellow eye has been lost because of complication of PDR. Yes. The next question is, Ajit, there are 2-3 more questions have come up. Neovascular fronts in the, Dr. Sohini again, Dr. Neovascular fronts in the extramacular area with no other change of DR in a de novo diabetic patient.
This requires fluorescein angiography mainly because, as you said, it is not possible that only to have a neovascularization without capillary non-perfusion areas or anything like that. Which means probably out of your thinking, you must have written all that. But there must be some significant capillary non-perfusion to be present before the neovascularization elsewhere to appear in diabetic patients.
Yeah. So in such patients, I may like to rule out a vascular block. If you do not
that
have.
Is also possible, but that also indicates there is some area of capillary non-perfusion in that area.
Yeah. Also remember, diabetic patients are not immune from not development of non-diabetic changes also, because they can develop other things also. Other question which has come up now is, I think you answered that, how to differentiate collateral, shunt and NVE. I think this has been covered. Collaterals are friendly vessels. They don't leak.
Yes.
And they are loop-like vessels, large cerebral vessels, generally on the disc or extramacular area.
They are mature vessels. Actually, collaterals, when collaterals are the beginning stage of, let us say, classic is branch retinal vein occlusion, where mild branch retinal vein occlusion, which is less than 5 disc areas, usually collaterals will start. That is the beginning. Then it becomes shunt or collateral. The collateral, once it matures, it becomes, it will not leak. If the balance is still towards more ischemia, then the neovascularization can happen, and which can leak profusely.
But Piyush, this is a very important, relevant point you have raised, because collaterals never treat, never, because they are friendly vessels.
Yes.
NVE always treat.
Yes.
So it is very important to differentiate. The next question he has asked is, can we diagnose macular ischemia without FA?
Yeah, we can with lot of PDRNs kind of hemorrhages will be there, and there will be a little bit of blanching will be there, and foveal reflex will be lost in these cases. So you suspect, and then the vision is not correlating with the fundus posterior pole appearance. That is a bigger indication. So with this, you raise your antennae, and if you are not too sure about the ischemia, again, you go for angiography. There is no harm in going for it.
So, Piyush, definitive diagnosis of this will come through angiography or even OCTA. That's a useful tool for ischemia. And suspicion, like Ajit Babu raises, tentacles going up, ischemia, when suddenly you have a lot of superficial hemorrhages.
Yes.
You see, diabetics, he said, is characterized by dot hemorrhages. But if you have a lot of superficial hemorrhages and a lot of cotton wool spots, this points towards ischemia. So this, you should remember. Okay.
So there's another question regarding classification. So once you classify the grade of retinopathy and you do an FFA for any reason, does the grade change? And another similar question is, does the DR severity ever come down with treatment, especially in the early stages?
Yeah, early stages, it is reversible. Early stages, it is reversible. And if you see the anti-VEGF therapy in PDR, again, with a number of injections, there is a reversal of diabetic retinopathy stage. So the possibilities now emerging is that it is again, you can reverse it with good control and good anti-VEGF treatments. Whereas you cannot expect that with a lot of fluctuating blood sugar and all. So I don't want to give this impression to you that you will tell the patient, yes, this is reversible. Don't give that. The second one, you asked something?
In FA, so
FA staging. FA staging, actually, there was a good attempt of staging for angiography in ETDRS. Actually, there is angiography-based grading, but that was like very loose. So I didn't attempt that here. Actually, I prepared that, but it is not giving a good direction.
But
And
let me tell
second
you
is
first,
the amount of CNP areas. No one has really attempted to see the extent of CNP areas, which is which will lead to neovascularization or significant vision loss or secondary complications like that. So that's why after angiography, you can say this has high propensity for complications like neovascularization and all, and it may require laser treatment. But I would not change the stage.
Right. So
what I was trying to tell Deepthi was there have been a lot of protocols and DRCR net sponsored studies where they have shown there is something known as DRSS, Diabetic Severity Scale. And this has, you see, come down after treatment with anti-VEGFs. You see, they have shown improvement of DRSS. And what is significant is if 2 levels decrease, that is significant. So these anti-VEGFs are promising. And you see, they show in, you can't distinguish that there are so many hemorrhages, exudates, they have come down. And very important is early stage, as Ajit said, early stage can reverse. But once it crosses severe, very severe, then it becomes very difficult. And one more question I think has come. Let's say, last only, is role of, in any case, treatment was not part of, DME was not part of this.
Yeah.
But role of subthreshold, But since Meenal has asked, maybe we can touch upon it.
I purposefully avoided DME and PDR. There is a lot of things to cover, but I said the next 2 classes are on that, and it will be injustice for me to go into their area and say, okay, last class it was covered.
So just because these young minds are very enthusiastic, so you see, in a patient who has center involving diabetic macular edema, this subthreshold yellow laser is definitely picking up as a treatment modality. There are some challenges here, but there have been 2 controlled trials which have been done in the usage of subthreshold laser, and is definitely indicated in DME, sentinel DME, and also in patients of, let me say, central leakage of CSR also. So where, this has shown promising results. So we will cover up in any case about this.
Yeah, next class anyhow we will.
You see, although anti-VEGFs rule the management of DME, anti-VEGFs or steroids, they rule the management of DME, but the relevance of subthreshold may come once you want to put a comma or full stop to the injections, because either you want to decrease the number of injections or you want to, make it finite treatment. Sometimes if it is extramacular, we go in for 532 laser, but if it is right on the fovea or center involving DME, then some subthreshold laser has a role. There's no doubt about that.
Simultaneously, you need to control the systems. The whole lecture I have spent on systemic parameters, their controls, derangements, everything. It is mainly to stimulate the young brains, mainly to concentrate there. It is in your gamut, and you can do very well in that area.
So any other questions from anybody else?
Most of the other questions are on DME, so I think we'll take that in the upcoming lectures. There's one question on classification, sir, if we have time. What is the classification system used in DR screening programs? Is there a classification system, or is it just referable or non-referable DR?
No, when it comes to screening, then you need to follow either ETDRS and modified Early-House classification. That's what I told. No, I didn't go into great detail because everyone will get bored and the time will get exhausted.
You see, what I would say is that
that's why I dwelled into it. Each lesion, how to grade and all, so that each follow-up, they should not miss either progression or regression of the lesions. What you are asking, regression of diabetes, diabetic retinopathy, that happens. That's why each lesion, I told you, for months to year, hemorrhages are more quick. It's weeks to months actually. In weeks, the old hemorrhages may disappear and new hemorrhages may appear. So whenever you are taking the photographs and then comparing follow-up to follow-up, you will be understanding all these lesions, what happening to them.
So I think the question primarily was about screening. So screening, Deepti, one should not miss up 2 things. One is VTDR, like vision-threatening diabetic retinopathy should not be missed. What is criminal? It is criminal to miss VTDR. VTDR means that vision-threatening diabetic lesions means PDR and DME. These can't be missed.
DME, yes.
Yeah, PDR and DME, nobody can miss. You see, in AIUS, we used to put up, at the entrance point only cameras just to pick up. And I will dwell upon that, findings later part, because Santosh has now appeared here.
Because
It's already 9 o'clock.
So the reason, I'm very sensitive towards this, because Ajit very well covered about the role of ophthalmology screening. So 2 things are worth emphasizing in this lecture. One is, I already emphasized 4-to-1 rule. Nobody should miss 4-to-1 rule, everybody, because I do not want severe NPDR and very severe to be missed. And second point is that 5 things which I have made a stamp at Center for Sight, where I will put a stamp. As soon as I see any diabetic patient, put a stamp there. And call all the patient, relatives, whosoever is there. Ye 5 cheezein control zarur karni hai. Like he already said that, but just to re-emphasize whatever he said, one is glycemia, blood pressure, then blood sugar, anemia, lipid levels, and kidney status. So these 5 things, you have to ingrain them, their patients, relative. Other very good point Ajit Babu said is a family problem. It's not, you can't ask patient to control diabetes and rest of the family is eating rasgullas every day. You see, problem is we ask the patient, bhai aap ye karo. So therefore, I have a habit of calling his wife, spouse, whosoever it is there, bhai aap sabko cooperate karna hai. Because if family does not cooperate, believe me, it's impossible. It's asking too much for that. Other thing is exercise. He said very important. 30 minutes of walk, morning, 30 minutes evening. Everybody, So I'll put a hand on the tummy of the patient. Isko andar karo. Believe me, as soon as this, it's not a joke. As soon as the tummy goes inside, believe me, this will come down. One drop, 1% drop in HbA1c.
Lalit,
Yeah.
in Bhopal, Indore, when the TV interviewer came, then I said Madhya Pradesh should be taken care of to control diabetes.
So it is thanks to this Pizza Hut and burgers and all, this tummy, we are copying West, but West is copying now East to, follow this. In any case, we'll go on and on, but two things which Ajit Babu said, control of 5 things, which I have emphasized again, and 4-to-1 ka rule. That is, I think, sufficient. And NPDR, mild to moderate, does not require treatment. Very severe NPDR, start thinking of treatment, especially if it is fellow eye or the other eye has been lost by complication of PDR. And DME, there is a definite protocol I think we'll discuss in the next talk. So with this, I think we thank the legendary Ajit Babu, who has, because you see, it is very difficult to deliver a talk on NPDR.
Yes.
On DME and PDR, everybody, will.
It's very focused topic.
Yeah. But in NPDR, you have to be very, very, methodical in, arranging your slides and all. So that is the reason I'm saying, let's thank Ajit Babu for starting this series on talks on diabetic retinopathy, because 2-3 more are likely to follow, which will dwell on a lot of questions and enthusiastic response, which is coming from the front benchers. So we thank Deepthi for very nicely coordinating and taking up all the questions.
And all the hot seaters also we should thank, because they have asked a lot of questions, right?
So Deepthi, announcement for?
Yes, sir. Next, just a second.
Meanwhile, thank you, Ajit, for sparing your time.
So next talk will be on Friday by Dr. Kim, and that will be on diabetic macular edema.
Wednesday, sir. Sorry.
So I took your role here.
Thank you so much. Thank you so much, sir.
Thanks a lot. Thank you, everybody.
Yes.
And have a nice weekend.
Good night. Yeah.
Okay.
Nice weekend. And
See
next
you.
Wednesday and Friday.
Yes.
We'll be there.
Wednesday, sir. Yeah. Feb 20.
All 3 diabetic lectures I will be there. After that, depends what Santosh gives next topics.
Yeah. Well, thank you, everybody, and bye.
Okay.